Good evening, everybody. Thank you. First of all, I would like to thank Dr. Amila and College of Ophthalmologists giving me the opportunity to talk on my subject and very in this 15 minutes. So in this versatile forum. so uh, looking after the patient during ophthalmology is a very wide topic. So I thought of talking mainly on the complications, what you are doing, the regional anesthetic blocks, the commonly you are using regional anesthetic blocks, and the complications where we have to attend and to manage, mainly the complications, and something related to the general anesthesia and like preparation and what we are doing in the theater and what is different from other anesthetic procedures and other theaters. What is the difference in ophthalmology? Right, okay. So, anesthesia for eye surgery is a unique challenge. It's totally different from other anesthetic practice. I have been doing anesthesia ophthalmology for a long time, so it's not a new area to me. So, what are the techniques we use is topical anesthesia. That, of course, commonly you are doing the topical anesthesia as well as local infiltration and regional blocks. There are advantages and disadvantages out of all these techniques. So in this talk, I will talk about the mainly on the general anesthetic preparation, evaluation, and specific consideration for certain type of eye surgeries, and also some complications and its management. So, objective of this ophthalmic anesthesia is there are few objectives. One is keeping the eye immobile. There's akinesia of the eye. So, and the regulation of the intraocular pressure. It is vital in intraocular surgeries. And control the systemic blood pressure is vital, especially surgeries like oculoplastic surgeries and intravitreal surgeries. And specifically management of oculocardiac reflex associated with certain type of surgeries, and control of the intraocular gas expansion and the injection of the gases and interaction with the anesthetic drugs. And smooth emergence of the patients is vital in the anesthesia, this type of surgeries. And post-operative analgesia also equally important. So what are the anesthetic techniques we use? As you know, you use most of the local anesthetic techniques, including infiltration, topical and nerve blocks and intracameral injections. So general anesthesia, mainly we are practicing general anesthesia and helping you in management of complication and topical anesthetic procedures. So obviously there are contraindications for local anesthetic, so you need to give general anesthesia. It's a part and parcel of ophthalmic practice. So what are the drugs we are using in the topical anesthesia? Cocaine was the first drug we used in 18th centuries. So now commonly used the lignocaine, 2% lignocaine, eye drops, and propiocaine, which is called alkane, and tetracaine. There are a little bit of pharmacological differences between these drugs. And local anesthetic drugs what use is lignocaine is a commonly one use because lignocaine is commonly available and is quick onset of action and short duration of action. So bupivacaine also commonly used one, and we commonly have 0.5% bupivacaine, but it comes in 0.25% to 0.75% concentrations. Bupivacaine is the other one which is not available to us. So dose of local anesthesia is very important. If you give correct dose, the very less likelihood of getting complications like toxicity. Lignocaine dose is 3 milligram per kilogram, but we give volumes, so we have to calculate like to the percentage is important. Like lignocaine, we have 2% lignocaine, mean 20 milligram per ml. If your patients need 150 milligram, you can use about 7.5 ml of local anesthetic lignocaine. So we combine with the lignocaine and adrenaline, dose is bit higher. We can go with a higher dose, 7 milligram per kg. Bupivacaine is 2 milligram per kilogram. We can calculate the dose according to the concentration. It comes as 0.5%, like 5 milligram per ml solution. So, depend on that, we have to calculate the dose to our patients. So also we use adjuvants. Adrenaline very important. When you use adrenaline, it increases the blood pressure and heart rate. Patients with the heart disease, ischemic heart disease, we have to be very careful when using the adrenaline, even though it's very low concentration. So a little bit of indication of for the general anesthesia, especially in children, we use very frequently. We use a lot of children. We do a lot of children for EUA, probing, and even cataract surgeries, squint surgeries, and DCR. So in adults, we use general anesthesia for uncooperated patients, mentally retarded patients, and oculoplasty. Most of the oculoplasty surgeries under general anesthesia. If you see this picture, eye operating theater is a bit different from the normal general theater or neurosurgical theater. Always anesthetics are kept aside. So, and anesthetic machines on the side. So it's a very busy theater, a very high turnover. So, patient care, we are sharing the airway. So we have to be very meticulous in anesthesia, giving anesthesia in eye theater. Even the surgical complications are minimal, but patient's complications are maximum. And the environmental complications are even worse. We are anesthetizing 2 tables with 1 minus staff in eye hospitals, right? And we don't have access to the patient. And if our anesthetic equipment like laryngeal mask have dislodged, and in the middle of the surgery, it's a nightmare. So we can't get access. And our monitors also side. So it's actually really challenging situation in a theater, in operating theater. So actually, there's in my training period, I don't like to anesthetize in the eye theater because always it's very difficult. Even the patients are not that complicated. Even though we said patients are not complicated, they are problematic. And basically, it's 2 extremes of patients, like pediatric patients, all the complicated patients with the syndromes, like Trocha-Collins syndromes, Down syndrome patients are very frequent. And other side, elderly patients with a lot of heart disease, ischemic heart disease, and diabetes with complications. So, how to prevent the complication? We have to assess the patient properly. Even for a local anesthesia technique, we recommend to assess as per a general anesthesia technique because these patients have a lot of issues. Even in between, this patient might go into general anesthesia or sedation, even they come for a local anesthesia technique. So, assessment from the medical school days, history, examination, investigations. And important thing is you have to take a proper history to identify what are the important things, whether patient is cooperative, whether patient's lying down position, that's more important because the cataract surgery or other surgery, patient has to be still and whether they are very anxious. So, do the physical examination at the blood pressure and any features of heart failure. That's really important. These patients cannot lie down. So the cardiac evaluation and control the blood pressure according to the guideline, and I think it was discussed earlier by Dr. Chamara. And the problem is we have patients coming for the cataract surgery and local anesthesia. I have experienced 2 patients develop acute heart failure, end up in the ICU. We have to intubate 2 patients and have to ventilate. They were perfectly okay, but in the surgery, blood pressure went up to 300 because if somebody touch your eye, your blood pressure goes up. There's one organ in the body other than something, one more organ, so your blood pressure goes up, right? Eye is one very important organ, so your blood pressure goes up, right? We check the blood pressure intraoperatively is always above 180, 200. So, because the doing cataract surgery is not very urgent or emergency thing, so you can control the blood pressure over 1 or 2 weeks' time. And the respiratory problem also important because some patients with the asthma or COPD, when you put your cover the face, they get very anxious, they say they can't breathe. So that's very common thing. So endocrine thing I don't discuss because Dr. Bulga already discussed about the glycemic control and so on. There are different guidelines for the blood sugar control. So that vary with the surgeon as well. So anticoagulation, because cataract surgery, as mentioned, is the least risk surgery. It's a vascular surgery. No need to stop aspirin or clopidogrel in general, right? The oculoplastic surgeries, always be careful about anticoagulant, warfarin, aspirin, and the antiplatelet like clopidogrel. It's a very severe risk. And investigation, actually, according to your history and examination, need to decide which investigation needed, depend on the patient. And basic investigation, the elderly patient, for other surgeries also we do ECG, blood sugar, and echo. All other investigation depend on your assessment of the patient. Pre-medication, for the general anesthetic practice, we give pre-medication, we give antiemetics, antacids, and sometimes sedatives. Always we try to avoid opioids. So also we have to know about the drug interaction. Your ophthalmic drugs, our anesthetic drugs, there are so many interactions. So I don't go in detail of this. And general anesthesia, what are the technique we use? There are a wide range of techniques. It depends on the anesthetist to anesthetize. Anesthesia depends on the surgery. So whatever the techniques, our target is keep the good control blood pressure, maintain the intraocular pressure, so and prevent and treat the oculocardial reflex in strabismus surgeries. And there are prevention of nausea, vomiting, especially oculoplastic surgeries and squint surgeries. So these are special consideration for the procedures, like if you're doing strabismus surgery, oculocardial reflex, oculogastric reflex. These reflexes are very common. They say 60% of strabismus get oculocardial reflex, and intraocular surgeries you have need to control the intraocular pressure very closely. Retinal surgeries also can cause oculocardial reflex. The important thing is use of nitrous oxide, because as anesthetic practice we use nitrous oxide. In our theaters we don't have air. Still in the IU hospital we have oxygen and nitrous oxide. We have requested several times, but we are not good, because we have to switch off nitrous oxide completely and giving 100% oxygen in VR surgeries. So preparation, basic things, keep fasting 6 hours. Important thing is we have to avoid overfasting, especially children's. They come the overfasting and diabetic patients. 10 hours, 12 hour fasting, they become hypoglycemic when you are waiting for surgeries, right? So other thing is when we tell our patients take clear fluid 2 hours before the surgery, sometimes they eat, so they drink milk, and it's big problem, especially our population. So children's we can control actually. Perioperative care, what are the techniques? Most of the times, about 90% surgery we do with this device called laryngeal mass airway. This is one of the most important device invented in 1990s. This has reduced the chance of intubation about 90% of patients. So laryngeal mass airway, but we have to correctly select the patients. So fasting is very important, because the risk of aspiration bit higher than the intubation with this device. And obese patients, I don't like to put LMAs, because the regurgitation aspiration is very common with the obese patients. And to control the intraocular pressure, we paralyze the patient, we give muscle relaxant and keep the intraocular pressure low. And we use nitrous oxide, but we avoid that situations like VR surgical situations. Smooth emergence. When you use this LMA, not like intubation, the recovery is very smooth. It doesn't increase the reflex, intubation reflex. Pain management also equally important, but with your local anesthetic, pain is very better control, because pain is not very severe in the ocular surgery. You can control the simple analgesics, paracetamol, cocodamol, or diclo, non-steroid anti-inflammatory drugs. Rarely you need opioids. So sedation, this is an important topic, but sedation of for eye surgeries, I have seen most of the surgeons don't like sedation, but some people like it. The current data, like US figures, they use sedation. More than 60% of their cataract topical patients. But UK figures is bit low, about 5% people, because they reduce their sedation by giving proper advice and proper preoperative assessment and education of the patient. So pure sedation is important. Actually, even our setup, relative number of patients, about 5-10% of patients need sedation because they are very anxious. They are very anxious. So, or general anesthesia or sedation. If you give a correct sedation, we can reduce the number of general anesthesia practice. In our setup also, how many cases we are doing under general anesthesia? In the list, cataract surgeries, about 6, 7, sometimes we do under general anesthesia. But if you give a proper sedation, with your cooperation, we can reduce the number of general anesthesia in our settings, and as Dr. Manav said, cost of the patients also can be reduced. So what I use benzodiazepine and the propofol. Propofol is as a general anesthetic, but I give sedation doses. So I have we do a lot of general anesthetic cases in private sector by giving propofol sedation, right? So I have no data, but I will do it. In addition, proper patient education also very important. So they will understand, and they will be more cooperative. And sometimes odd positions during surgery. You know, some of our patients, they can't lie down, right? So they can't lie down. We have to properly position the patients for the surgeries. So sometimes you might be doing this surgery in the seated up position, or head down position, because this position in patients is very important in theater. So otherwise, these ladies or patients with orthopnea, patients with COPD, they can't in a supine position. So at last, I'll talk a little bit about the complication related to anesthesia. What are the main complication? Local anesthetic toxicity, intravascular injection local anesthetic toxicity. This is a very serious complication, as you know. If you exceed the toxic dose, or if you give intravascular injection local anesthetic, can develop toxicity. The toxicity severely depends on the type of local anesthetic if you use. So bupivacaine is more cardiac toxic. Lignocaine is more CNS toxic. So what the important thing is, CNS toxic patients, you get a numbness, tinnitus, metallic taste. Those are the initial symptoms. And cardiac arrest and bradycardia is a late sign in the lignocaine toxicity. But bupivacaine, the cardiac toxic, more cardiac toxic. So the management, basically, we have to give oxygen and the monitoring facilities. The drug of choice and the antidote is intralipid. It's called 20-lipid intralipid. Is the drug of choice. So we should be give intralipid, they get severe toxicity. Right? We have the bolus dose and the infusion of intralipid. So most of the times we don't have intralipid, but we use propofol sometimes. The propofol contain lipids. We can use propofol, right? So the one is oculocardiac reflex. It's a common thing, especially squint surgeries. About 60% to 80% of squint surgeries, you can see the oculocardiac reflex. So why they get it? Like pre-op anxiety, hypoxia, increased vagal tone. These patients are high risk of getting oculocardiac reflex. It's sudden onset reflex. Immediately heart rate is 60, then become 20. It's very quickly you get it, and you get bradycardia, ectopic AV block, and cardiac arrest. As soon as you stop stimulation, most of the times it will reverse back. So how can you prevent it? If you inject local anesthetic to the muscle before you pulling, it will reduce the chance of getting toxicity. And usually pre-atropinize patients. You can become heart rate to say low. I block the vagal. So oculocardiac reflex, respiratory reflex, and oculometic reflex. Also trigeminal reflex, and associated with the high incidence of nausea and vomiting in squint surgeries. The one is brainstem anesthesia. This is a serious but rare complication. It is a bit of late complication after, especially the retrobulbar block. So patient completely become respiratory arrest or cardiac arrest, or can develop neurological deficit. So we need to have facilities to resuscitate the patient in that type of situation. Times may need intubation and ventilation. Okay. Postoperative nausea, vomiting also common with some eye surgeries. So we can use our anti-emetic drugs. The ondansetron is a drug which is very less side effects. We can use without any problem. And dexamethasone, other one, is has a very good anti-emetic effect. Okay, at last my take-home message is looking after eye patient is a unique challenge, right? No local anesthesia technique free of severe systemic side effects. The goal of anesthesia to provide smooth intubation, extubation, and the control intraocular pressure. Complications of ophthalmic anesthesia are rare, but both vision and life-threatening. So ventilation oxygen must be monitored, and facilities should be available to resuscitate the patient at all the times. Thank you very much.